But in this discussion, you're talking about different types of cancer treatment, the cost, and also the emotional turmoil that patients who are undergoing cancer treatment are going through. And so with me, I have Dr. Anne, Dr. Angela, and also a cancer survivor, Violet. They'll be joining me later on because right now, I'd like us to look at the cancer statistics. And, you know, cancer menace, a number of cases of cancer in Kenya. When you talk about cancer in Kenya, not only in Kenya, but globally, you're also talking about cancer that affects men and women. Now, a total of 47,887 new cancer cases are reported annually. Now, out of this, a total of 19,199 cancer cases are in men across the ages. So it doesn't matter your age. You can't be told that you have cancer at any age every year. Now, 28,688 cancer cases are reported in women every year, and deaths due to cancer are, let me give you that figure now. When it comes to deaths due to cancer, we're talking about 32,987. That's a huge number. Then that is death reported annually. Now, the leading causes of cancer, and that is what Dr. Angela talked to us about, and the World Health Organization states that approximately 70% of cancer patients from the less fortunate societies die due to smoking, alcohol use, aging, poor diet, and of course the lifestyle of failing to use a cancer screening test. So those are just some of the causes, and of course Dr. Angela earlier on had talked to us about it. Now, we need to have a look. Let me give you a breakdown of the leading cancer cases in Kenya. So we have breast cancer being one of them, and is the most frequent cancer in Kenya, with about 6,000 new cases every year. So every year, cases of breast cancer are reported. Now, cervical cancer ranks as the second most frequent cancer and the leading cause of the cancer deaths among Kenyan women. And of course, Dr. Anne and Dr. Angela will be talking to us about the causes of cervical cancer. So far, we know there is a vaccine that's being given to children from the age of 11 onwards. And so many parents have caused uproar about it. But we will be talking to the two doctors just to talk to us about the cervical cancer. Now, let's look at the global data. In 2018 shows that prostate cancer is the leading cancer in men, followed by cancer of the esophagus, and the cancer of the esophagus ranked the leading killer cancer in Kenya. Now, the National Cancer Institute 2019 report shows that children under the age of 18 years are more prone to leukemia, which is most common with 17% prevalence rate, followed by non-Hodgkin's lymphoma, which 15% rate cancer vaccines. So when you're talking about, let's talk about the cancer vaccines that's available. You're looking at the HPV cancer, which has to do with matters of cervical cancer. And of course, let me just wind up with these statistics as we head towards our conversation. The World Health Organization 2018 factors shows that cancer is the second leading cause of death globally and is responsible for an estimated 9.6 million deaths in 2018 globally, and about 1 in 6 deaths is due to cancer. Now, approximately 70% of deaths from cancer occur in low and middle income countries. Now, around 1/3 of deaths from cancer are due to the 5 leading behavioral and dietary risks: high body mass index, which the doctors talked about. It has to do with colon cancer, low fruit and vegetable intake, lack of physical activity, tobacco use, and alcohol use. Now, let me end that statistic there and bring in, Violet, who's a cancer-free patient. So, Violet, surgery was done. You declared cancer-free. Talk to us about your journey after that. Has it been the same on what you ate? Are you still on medication?
After treatment, first of all, I went into depression for quite some time because I was just scared, first of all, because of the colostomy. I didn't even know how to handle it. I didn't know how to go about it. And then I got out of depression because I found a support group where I went and I shared my story, and I found people with similar stories, and I was able to accept myself from there. And life since then has not been hard. It's been okay right now. And I'm able to share my story. I'm able to encourage others. And slowly and surely I'm getting back to life. My life is slowly getting back to normal.
All right. And we are really happy that you're cancer-free, you're a victor. And talk to us about, that emotional turmoil that you went through during the treatment and also right now.
During the treatment, I'd actually given up in life. I didn't even want to live. I think I was just fighting because everybody was telling me, go for chemotherapy. Everybody was telling me, you need to do this, you need to live. But as for me, I didn't even want to live that particular moment. So it took a lot of counseling from friends. It took a lot of counseling from pastors. And slowly I was able to overcome.
All right. And the first thing that runs into the mind of someone once you've been told, you've gotten the medical reports that you have cancer, the first thing that I've heard from stories of people who've been told that they have cancer is death. That is what runs into their mind. Was it the same story for you?
Yes, when I was first told I had cancer, and I knew I was straight away going to die. And at that particular time, I was ready even for death because I already had a colostomy. It was not easy for me. Actually, having a colostomy is what shocked me more than even being told that I had cancer. So by the time they were telling me I have cancer and already had a colostomy, I looked at it as if they're telling me nothing. I'm already dead.
All right. And before I bring in Dr. Harry, talk to us about the cost of cancer. How expensive was it for you?
Cancer is very expensive, especially, I think when I was first diagnosed, my family wanted me to maybe try India and something of the sort. But I didn't have the finances to go to India. And I remember one person in our family saying, if we wait for us to raise the finances for me to go to India, then we risk the cancer spreading. So I just decided to go to Kenyatta National Hospital. And at least at Kenyatta, it's not as expensive as maybe other private facilities. I must say that. And as much as it was expensive, I had friends coming to help me. My parents also had a small piece of land that they sold to help me with financing the treatment. And then NHIF also helped. They paid some of my sessions, although they don't cater for blood works and all that, but they assisted.
How was it emotionally for your family members? Because this is a season that you're really low emotionally and your family was seeing you looking so down. How was it for them?
Well, I can't even tell how it was for them because every time they would come near me, they would pretend, they would smile, they would put on, that brave face. But deep down, I would feel them, I would feel the emotions. They were really scared.
All right. So, Dr. Anne, we are talking about, the cost of treatment, and it's good Violet is also talking about it, and especially for families from low-income households who cannot even afford a treatment.
Yes, that is quite a concern, and especially considering the cost of the chemotherapy itself, the cost of the surgery, the post-surgical care, then radiation. This is quite a strain on most of the patients, especially because a large portion of them are from low socioeconomic status. Yeah, so it becomes quite a challenge to now manage cancer from the point of diagnosis going forwards. And that really contributes again to the number of poor outcomes because of just that lack of access to resources.
And which is the cheapest? Probably one of the viewers might be wondering, which is the cheapest treatment for cancer?
There is no one-fits-all kind of therapy for cancers, as Dr. Angela had cited earlier. We have a whole world of cancers, if I might put it across that way, and there are over 100, and each one of them has its own specific regimen that works for it. And then again, what makes the treatment so diverse is also that the fact that patients present at different stages. So the treatment for stage 1 will definitely not be the treatment for stage 2. It will not be the treatment for stage 4 patient. So that makes it another jungle when it comes to treatment. So I would say that the treatment will now be tailor-made for that particular patient who has come to me that particular day based on those factors.
All right. And Dr. Angela, you know, when you're thinking about treatment, when cancer patients are thinking about treatment, the first thing that comes into their mind is going abroad, going to India for treatment. Why are Kenyans looking at India for treatment instead of looking for treatment locally?
So basically, I think it's one thing is lack of confidence. And that lack of confidence is really due to lack of information about our healthcare system. So when you get sick in this country, you have to sort of, actually you can start from the primary healthcare level. So a dispensary somewhere with abdominal pain, for example, the person there doesn't know who to send you to. So next you will go to your district or sub-county hospital, then your hospital, finally be referred. And when you're referred, then you have to be taken to the correct doctor, and then that doctor has to constitute a team. So there's really lack of information to our patients on where to go and get help when they're suspected to have cancer, because usually it is a suspicion. And what we really need is what the government is looking to do, where they will set up regional cancer centers. And right now the focus is on 14 counties in Kenya, so that that issue of referring patients from dispensary all the way to the national hospital over months of lost time in treatment, and having no information on what to do and how to handle can stop. So that if you're in Western region, then you can go to Kakamega, Kisii, Kisumu. If you're in Northeastern, you can go to Garissa, and there's a cancer center. Then there are trained personnel who are able to take care of you. So initially with just 2 hospitals, MTRH and KNH, and we're talking about public because this is where most of our patients go to. Patients would start off with zero information.
Right.
And then you'd find that the person who had been treated had been frustrated because of long wait times and long queues and rude staff, and eventually had to collect money and travel out of the country, and where they got very quick service. So that is the information that will come to our patients, that I was sick, I got frustrated in Kenya, and I went to India, and the service was so quick, and the staff were so gentle and understanding, so don't stay in Kenya.
Right.
But we are really looking to that, and the government are looking to do something.
All right. So, Daktari, let's talk about the consistency of treatment, because, and especially, not all Kenyans can afford, cancer treatment in terms of finances. So, the consistency here, the reason that's why I'm talking about it, it's because you'll see a family is able to afford money, maybe just for the first chemotherapy session, the second and the third, they're not able to afford.
Well, so it's expensive to get cancer treatment. Chemotherapy, 6 to 12 cycles, will cost you hundreds of thousands. Radiotherapy will cost you the same. Surgery can go all the way to $1 million just to have that hemicolectomy done. So usually that's why we say that any new patient coming to see an oncologist or any healthcare worker should, at that first visit, be discussed in a multidisciplinary team that has all these specialties that would need to manage this patient. And along with that, there would be a counselor that can look at that patient's financial status, so that I have no business starting a patient on any aspect of the multimodality treatment that they require as Angela McLeod. I should not do that, because even if I was able to take them through chemotherapy, do I know that they will be able to do their surgery or their radiotherapy, or will they stop with just one modality? So the whole team must be there, assess the financial status, and decide, can this patient be given care, full care at a public hospital? And the good thing with our public facilities, and they will be the majority very soon if the government steps up as it's planning to do, is that NHIF will cover usually between 60 to 80% of the cost of both the surgery, of the chemotherapy, of the radiotherapy. And the follow-up care might be what the patient needs to handle. And therefore, if I know that a patient cannot afford private, then I put them in a public facility. But usually I look at the total cost of treatment, and I tell them you will need to add this amount for your lab test, which NHIF does not cover. For chemotherapy, if NHIF will cover fully, for some of the cheaper chemos, they'll tell them you either need to not add or you just need to add this much. And
Right.
for surgery, and for radiotherapy, likewise, because you have to look at that whole treatment plan from the day zero when the patient comes to you.
All right.
Anything that you will not get good outcomes.
All right. So, Violet, so talk to us about, yes, you've talked to us about, the cost of treatment, how it was expensive. So here you are, you've been done for that surgery. Life after that, how costly has it been for you?
Yeah, the treatment was very expensive, I must say that, because one session of chemotherapy was around 30,000. And I went for 12 sessions, and NHIF only paid for 6. And then every time you go for chemotherapy, you also have to do a lot of blood works, so which NHIF does not cater for. And then there's also a lot of imaging. You have to do CT scans, MRI in between, and sometimes NHIF will cover for 2 or maybe 1. So the rest of the treatment you'll just have to do it yourself.
All right. So, Dr. Anya Wira, let's bring in the conversation about, cervical cancer, because you're focusing on different types of cancer. And when it comes to cervical cancer, what is the cause of cervical cancer? Because many people have always thought, I've always known that cervical cancer, you can only get it through a sexually transmitted virus.
Well, as we had earlier discussed, the causes of cancer are actually multifactorial. But specifically, when we narrow down to cervical cancer, we usually, as a medical practitioners, we look at HPV, human papilloma virus. Okay, human papilloma virus infection, even early on in childhood, causes a structural change in the cervical tissue, and then that will definitely predispose to risk of getting the tissue change will predispose to dispose the patient to a very high chance of getting the cervical cancer, amongst other risk factors like age, okay, familial factors, that is genetic factors. And when you're talking about genetic factors, you're talking about mutations at the DNA level, okay. Our bodies have a mechanism of suppressing tumors through what we call tumor suppressive genes, like P53, like BRCA1, BRCA2, amongst others. Now, this actually points to all other types of cancers. So when we have a problem at the DNA level, that is a contributing factor. Then another factor is the immune competence of a patient. So if you're immune compromised, you're definitely predisposed to getting cervical cancer, amongst other risk factors.
Mm-hmm. And so at that point, I think if I got you right, it is that also people with HIV and AIDS are prone to cervical cancer?
Yes, they are.
And so what is the treatment of cervical cancer?
The cervical cancer treatment, again, depends on the stages. If you have, you can have localized cancer, then you can have invasive cancer, then you go on to stage 4, whereby we have distant metastases. Now, if you have a localized cancer, then the treatment is surgical, definitely. You do a localized excision, okay? Then if you go to stage 2, whereby now the cancer is spreading to the nearby tissues, then you're going to do a wider excision, okay? And then if you go to stage 3, whereby, again, now this cervical cancer has spread even to the surrounding lymph nodes, then you do an even wider excision, okay, going up to the lymph nodes. Mm-hmm. And then if it's stage 4, definitely this cancer has spread to all the tissues. What we call distant metastases can even go to the brain, it can go to the spine. So depending now on where the cancer has spread, you can do now focused care. First of all, you can do, if you remember, neoadjuvant chemotherapy. We shrink the size of the tumor. Then we do a surgical excision to debulk the tumor. That is to make the life of the patient easier and more comfortable, to also reduce pain. And then we have radiotherapy. And again, now localized or focused treatment. If you have spread to, let's say, the spine, you'll definitely need to pick actually the metastasis. You need to do an MRI of the spine and then now involve an orthopedic. Okay, so now at stage 4, we have a multidisciplinary approach. Though even from stage 1, okay, we should definitely have a multidisciplinary approach.
All right, so Dr. Angela, so who are the carriers of this virus that causes cervical cancer in women? Is it the men or the women? And if it is the men, then it means women ought to be very careful with the number of partners that they have in their life.
I'll say that HPV viruses are multiple. There are several strains, and not all of them will give you cervical cancer. There are about 9 different strains which have now been isolated and are linked to cervical cancer. The others, even if you did have them, would not result in cervical cancer. So the thing is that men tend to be asymptomatic carriers. So they have it in their system. It is not causing them any problem. Can give them penile cancer and anal cancer, especially if they have HIV. But if they don't, then they can carry it all their life without them even knowing that they have it. And therefore, I think it's extremely important that, so right now, we're advocating for just girls to be vaccinated, but it really just need to be both girls and boys. And the more developed countries are vaccinating both girls and boys, because even if you are socially responsible and using protection as a woman, and your husband was faithful to you, don't know about their early days, and whether they got this virus at a younger age, they're still carriers. And people think you have to be having multiple sexual partners, but no. You just need that one man, even if he's faithful, to have been exposed earlier and carrying it asymptomatically. Having said that, even women do get some HPV infection, and they could be the one infecting them. And I mean, it's both ways.
All right.
The vaccination is really what will help us.
In fact, I was about to ask you about the vaccination, Doctor. You just picked up my mind. So let me pick it up from where you've left it. The HPV vaccination. And this is something that parents are asking. My kid is in such a younger age, a tender age. My kid is not sexually active. Why should my kid be given this vaccine and the safety of my child once they have the vaccine?
Well, because the virus is everywhere. It is ubiquitous. You can easily get it once you're sexually active. And the thing is, the man can remain asymptomatic for life. The woman can take the next 10 to 20 years of having that virus and not get cervical cancer until 20 years later. So you need to vaccinate a young girl and a young boy before they get the virus, so that you really reduce their risk of getting an infection once they're exposed to this in their sexual years. And I know there has been lots of negative information about the vaccine being laced with contraceptives, with all sorts of toxic products. But the data from out there, people who have been using the vaccine for years, the Western world, really they've been able to control and eliminate cervical cancer. And we have not seen all the fears that are being raised manifesting in those countries. So I think it's really information that is ill-informed. We're all ill-informed about the safety of HPV. It is really quite safe. And we have to look at those who have been using it for years and what is really the effect. So we are losing our women to cervical cancer. They are not. Able to have babies. So I know you could say that the African version of the vaccine is what is being laced, but really there hasn't been really proper proof of that.
All right. So ladies, once again, just stay with me because we need to take another commercial break. We'll be right back as we continue with this discussion about different types of cancer. And when we come back, we shall be focusing on the awareness when it comes to checkups, cancer issues, and also how COVID-19 has also affected the treatment of cancer.